Hello, everyone, and welcome to HeadWise, the weekly videocast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. Today, we are doing our monthly headache news episode with Dr. Tim Smith. Hello, Dr. Smith. How are you doing today?
Doing very well. Thanks again.
Thank you for being here. Dr. Smith is a regular. Most of our audience is very familiar with him. We all love him. He is a regular because of his experience in migraine clinical trials as the CEO of Study Metrics Research. He is also a board member of the National Headache Foundation. He does an amazing job of discussing all the new information out there every time we have one of these news episodes, and we have a lot to ask him about today. So let's start with all of our new medical information. We're going to begin with a study that will be interesting to parents of children with migraine, or possibly people who had migraine as children. It's interesting to me. I love this study. There's a group that looked at the association of growing pains in children and migraine. So what did they find? I got to tell you, I had horrible growing pains as a child. My poor father sat in bed at night. I'd yell and wake him up, and he'd massage my legs. So I find this so interesting. So tell us what they found, Dr. Smith.
I think a lot of our viewership will find this interesting because so many did have so-called growing pains, and actually that's still what we call it medically, because we don't have a pathophysiologic construct they looked at this. There's no blood flow abnormalities, there are no bone abnormalities, and there's no inflammation in the tissues, and but it can be severely painful, as it turns out. So this group from Brazil did a cross-sectional prospective study. So they identified these children and a control group that had these growing pains, and they followed them for 5 years, looking at lots of different variables. And what they found was that if children had growing pains, they would have, and these are the severe bothersome leg pains, especially after a day of physical activity and the like. And they found that 76%, about 3/4 of children with growing pain, will have the diagnosis of migraine within 5 years. And then 22% of the children without growing pain will have migraine. So it's not a necessary requirement, but it's about 3 times more common in those patients, migraine is, than in patients without growing pains. So pretty interesting phenomenon. I've never really thought about this before, and someone close to me, has talked about having severe growing pains when she was growing up, and she has significant migraine, history for 50 years, and dealt with it, as best we could, like all of us do. But that sort of caught my eye when I saw that, just because of that personal knowledge, and sort of an interesting, outcome from this study. And it was well done. I think it's believable. So, good for those folks in Brazil for looking at this.
Yeah. Did they give a reason, any possible explanations or hypotheses on why they thought this occurred?
Well, of course, it's hypothetical. Nobody knows for sure, but they discussed potential for sort of a comorbidity, because the central nervous system is more sensitive and less adept at dampening out pain. We talk about allodynia. We talk about comorbid painful conditions. And this may be another expression of that. The migraine brain is clearly different. The nervous system is different in migraine patients. And this may be yet another, distinguishing factor. So I don't think it means that if if a child has growing pains, they're doomed to have a life of migraine. But it certainly, points in that direction. And if they have a family history, and if they have other, manifestations, particularly recurrent sick stomachs and things like that.
Mm.
We are aware of how, the cyclic vomiting of childhood and those kinds of things can be have a migraine core basis to their physiology, and this
Right.
may wind up being something similar to that.
Right. Okay, well, that is super interesting. Let's go ahead and move on to our next new study. It was just published looking at a very large data set, in fact, over 10,000 people, to see if those were with migraine were at higher risk for death from cardiovascular disease. And let's be honest, people have looked at this before. I think we've even discussed it on this podcast. But what did this particular group find?
This was an interesting study. Now, what they did is they took an existing database and did a new analysis on it. And this database we refer to as the NHANES database, NHANES. It stands for the National Health and Nutrition Examination Survey. This has been going on since it was done like between 1999 into the mid 2004, 2005, somewhere in there. And they've got thousands and thousands of detailed medical histories and content on each patient. And they answered pages and pages of questionnaires. That's all been chronicled in there. And so, basically they found that patients with a history of migraine, and I should qualify this because what they were able to search on was the diagnosis of migraine. And this is all self-reported, by the way.
Right.
The patients reported they had migraine or severe headache.
Right.
And so if the patients have migraine or severe headache, their hazard ratio is 1.3, which is 0.3. I mean, that equates to a 30% increase risk of cardiovascular disease over the patients who don't have migraine. And this is a large population of patients over a long period of time. So you could, the questions become, well, were there other differences in those populations? Do we know? And the unfortunate thing is we don't know. And that's the problem with observational data is it's a good hypothesis generator. It doesn't explain everything, but it tells you where those associations are. And association, as my stats professor told me, association does not equal correlation. So
does not equal causation.
Our causation, correlation does not equal causation.
Yeah.
So I said it wrong, but anyway, it's even and the association was higher in Hispanic white populations. It was higher in thin people, as it turns out, higher in people who don't have what we call metabolic syndrome. This is people who have diabetes or prediabetes. We do know that patients with migraine do have vascular abnormalities that people without migraine don't have.
Right. And
there's a lot of inflammation. There are a lot of secondary changes that occur from having migraine over time. And it's clear that the response is not the same. So
let's summarize the results. The people that were most at risk were thin, female, non-Hispanic, and under the age of 46. Is that what it was?
Yep. Younger, thinner. Yeah.
Yeah. And so that it is interesting because they did seem like healthy people, and they were most at risk in this paper. So that is interesting. But I do think the take home, like you said, is healthy lifestyle will hopefully help both our migraine issues and protect us against these cardiovascular risk factors that they found. Is there anything else on that paper that we've missed?
No, I think that's plenty. It's an interesting paper. So there's a lot of sub analyses that they did on that too. So it was pretty interesting to read through.
So the next one I really love because I find it so interesting when we have a study in the cluster headache population, because we so rarely get much research for them, and it is what we know to be the most painful phenomenon in mankind. And also I love genetic studies because I feel like genetic studies can really push forward a field. And so this next study, even though it's very tiny, it satisfies those two requirements. It's a genetic study in the cluster headache population, And so I'm excited. Can you please tell us what this little study found?
Sure. This was a study that, as you said, it was a small study. It was looking at a small cohort of patients that belonged to a family of cluster headache sufferers. So, cluster headache can occur randomly, and
Yeah.
it can occur in families. And there's the familial hemiplegic, and there's their subtype that is known to occur in patients with a certain defect, in the genomic defect. But that's for migraine, for familial hemiplegic migraine. So for cluster, we don't have as clear a definition on that. There are a couple or more genomic abnormalities, or associations, we should say, that tend to occur in patients with cluster headache, and we've known about these for years. And the two that they looked at in this small study they're called HCR TR2, and the other one is the CLOCK, or clock gene. And so we know that both of those have associations with cluster headache. And there's been a lot of research looking into what those defects cause and what the pathophysiology happens resulting from that. And this study is totally different, because what they do with this is they go and they found a multi-generational family that had this preponderance for cluster headaches. And even more than that, they had what they kind of had a familial periodicity. And so what that means is the patient's cluster headaches behave very similar from individual to individual, from individual to individual. Cluster headache can vary. We have these wide ranges. Frequency of attacks can be anywhere from every other day up to 8 times in a 24-hour period. That's a huge difference. And we know that a cluster attack might be as short as 6 weeks, but it might be as long as 3 months or more, or 5. And there's a tendency for it to occur circumannually, like in the spring and the fall. Some people just have it in the fall. Some people have it just in the spring. Sometimes people have both. But there's clearly some differences across the big population. But if you get down to these families, you can find sometimes families that not only have cluster headache, multiple members have cluster headache, but their clusters behave very closely to one another. So, they might have an 8-week cluster attack where it's, 3 clusters every night, and then 9 months of reprieve or something like that before the next.
That sounds like a nightmare, like everyone in the household having attacks at the same time. It just sounds terrible, but I'm sorry to interrupt. Go ahead.
No, but anyway, they found this family that had this story, and they did genome-wide assessment. They mapped out their entire genome. And when they looked at this clock gene variant and the HCR-TR2 variant, and 2 of these patients who had identical behavior of cluster headache attacks in the family, they had both of those gene variants in their human genome. So this is this is the first time we've ever seen this co-expression of these genes that we know that are somehow related to cluster. And it was interesting that both of those defects were found in this family, and the family's expression of their cluster headache attacks was very, very similar. So it doesn't answer all of our questions, but it kind of points in a new direction for us, and to think about, we should probably be looking at these cluster associated gene variants more in a potentially, and maybe there's multiple. We should be looking for clusters of abnormalities, and so cluster becomes a coincidental use
clusters of genes that come together. Yes. And the clock gene actually is a gene that has to do with periodicity, correct, and timing of these attacks. So that it is very interesting.
Yep.
So moving on to our next study, this one is probably one of the most interesting ones we're going to talk about today. And there was even a commentary written on it in the journal called Headache. So as many of us know, some of us get aura with our migraine attacks and some of us don't. And there is data showing that aura may be caused by something called cortical spreading depression or depolarization. A lot of our audience has probably heard of this. It's sort of a wave of excitation of brain cells, followed by the inhibition of the neuronal activity after the excitation. And there's always been a question hanging in the balance, so to speak, as to whether this aura phenomenon, actually then causes the pain of the migraine attack itself. And so somebody who was really motivated went ahead and did a little study here and published this paper trying to find out if that was true. So what did they do and what did they find?
Yeah, so to your point, the presumption has been, or at least the working theory is that, this spreading cortical depolarization wave, it's a mouthful, but basically it's this thing that happens to the brain, the surface of the brain, the cortex of the brain, that's been observed to occur at the same time or commensurately with visual aura, and then heralds the onset of the migraine, headache pain, and other disabling symptoms. And the presumption has been that the aura is the initiating event, and that for people who if it spreads across their occipital cortex, the cortex of the back of their head where your visual recognition is, that you'll see it, but if it occurs somewhere else, it may be silent. And so we talked about these silent auras that may be occurring. And there have been studies that suggested that was the case, and some that, it was hard to prove. And what these researchers did, and this is a German study that was done by our very respected research group, and they do a lot of functional imaging. And what they did, this is a case study, so it's not a huge study of multiple patients. It's a study of one person who
one person. All this data came from one very motivated subject.
Yeah, who did a very heroic job of
he did. Thank you, sir.
Presenting for daily MRIs, say functional MRI
Yeah.
assessment, so they could see what was actually going on in this man's brain.
Yeah.
And as fate would have it, of course, he had some days he didn't have migraine, and some days he did, as usual. That's the most common course. But then he also had some headaches with aura and some without. So they could look at, these different attacks within the same individual, and could understand which parts of the brain were lighting up and were abnormal, before and during the attack. And what they found was this aura, which they could, the CSD, the cortical spreading depression or depolarization, was sometimes present and sometimes it wasn't. But it didn't correlate with the onset of migraine pain very well, and people had plenty of migraine. So there was not a silent, sort of aura that this person had for his non-aura headaches. So the presumption that he had a spreading depolarization wave that just didn't get recognized was basically rejected. That we know that that's not what happened in this man's brain when he wasn't having when he didn't have an aura. He was not having a depolarization wave somewhere where it just wasn't recognized. So that was kind of an interesting thing, and it's changing. I wouldn't say it's totally debunked, the thought, but it's pretty strong evidence that what we've assumed about, or what a lot of us have assumed about the spreading depolarization wave, may not be true. And the current thinking of these authors is that it may just be what they call a migraine epiphenomenon. And if your migraine brain is sensitive, you may be prone to having these spreading depolarization waves just because it doesn't take much to cause them to fire. And that's more of a result of having a sensitive brain than, being associated with actual causation to trigger the migraine attack. The other interesting thing that they saw is that the areas of the hypothalamus, which is kind of like your centers for your involuntary and autonomic, activities of your body, this tended to be abnormal as much as 48 hours prior to an attack. So this makes us think more about the phenomenon we call prodrome, or some premonitory symptoms that may be associated with a change of mood or change of energy levels or some other symptoms that patients may have. And there's been a lot of study on this. We talked about one recently with one of the new migraine drugs having effect if taken during this premonitory phase or the prodrome. And so it kind of reaffirms that there's some basic brainstem or hypothalamic abnormality that makes us the way we are and puts us at risk. And that this, if we pay attention, we may be able to identify those symptoms that predict onset of migraine, but it's not aura. So
okay,
sort of
so
interesting.
yeah, so to summarize on that one, it might just be one patient, one very heroic patient, but it looked like with data from him that perhaps cortical spreading depolarization is not required for migraine to occur. And so that was an interesting study, I think, for everyone. Are there any other studies that were published recently that we should tell people about?
Well, I did. There was just the journal just hit my desk today, and there's an article in the Journal of Neurology this month that looks at what they refer to as a late response to the anti-CGRP monoclonal antibodies. And so we all know this class of drugs that includes iranumab or Aimovig, and then there's galcanezumab or Emgality. There's the pimenazumab or Ajovy and the eptinezumab or Vyepti. These are the 4 monoclonal antibodies that block CGRP effects in the body that are proven to be excellent migraine prophylaxis drugs. And what they looked at in this is they looked at response rate beyond the first 3 months for patients. And if you look at response rates at 12 weeks, 3 months in, the response rate is pretty much what you see reported in the literature. About 66% of people had achieved a 50% reduction in their monthly migraine days. And they tracked these folks out even further. And of the patients who had not achieved a response at the 12-week mark, if they looked at them at 24 weeks in, so 6 months, another 55% had achieved that 50% reduction. So over half of the population that had not achieved that reduction by 3 months had achieved it by 6 months. So it's sort of making us look at this a little differently. And I will say that, we didn't see these kinds of results in the clinical trials, but in this in this study, which was a prospective, what we call a real life study, it just in regular clinic use with whatever support and instruction is usually given for patients with migraine in clinic, and they attributed this to the intervention itself. Right. I guess one of the shortcomings of the study is there could have been other things, since this wasn't a controlled trial, that could have potentially contributed, but better is better. And we don't tend to argue with success. We like it when people do better, and if they get better, right, that's even better. But it sort of calls into question the notion of giving it for 2 or 3 months and then giving up on it if you haven't gotten where you want to be. And I thought the most interesting part of it, I put on my glasses that I had, I wanted to look at this, make sure I get it right, because I don't want to misquote it. This is a brand new article I just got today. And when they looked at that subpopulation that were late responders, they differed from the early responders with respect to their body mass index. They had higher BMIs, significantly higher BMIs. They had a history of more treatment failures. They were more likely to have psychiatric diagnoses. Then they were, interestingly, and I don't know if I understand this one, but it was a definite phenomenon, and that is they were less likely to have unilateral pain and more likely to have
pain on one side. They were
more
more
likely to have
either
the whole head or both sides.
Right.
then there was a slight difference too for cranial autonomic symptoms, or meaning like bloodshot eye or tearing of the eye or runny nose, congestion, those kinds of things. Or
So the people who responded late had more cranial autonomic symptoms?
yeah, and
Okay.
they had a little more allodynia too. So that was this allodynia being a heightened sensitivity to painful or non-painful phenomena.
Right.
So your brain perceives pain when you're not
Right.
experiencing a painful injury. So skin sensitivity and the like that we talk about from time to time. That interesting paper, it sort of looked at a population that deserves looking at, and gives us a little more color commentary on things to expect. If I think practicing clinicians might look at this and say, for my patients that may be a little overweight or who have failed lots of things in the past, I might give them a little more benefit of the doubt and treat longer before we give up on this. And, and if patients have had a lot of treatment failures in the past, most of them in my book have been pretty desperate to try to get something, that helps. And it may be that they just need a little longer trial of the stuff that they're receiving.
Of the monoclonal antibody. And as someone who's had migraine my whole life and had a number of treatments fail me, I like to say it that way instead of the other way around. I didn't fail, the treatment failed me. I would be very motivated to keep trying for 6 months or so, if I knew that some data showed that might help me. So I think that's a very important study, and the take-home message on that one is perhaps if you are going through the monoclonal antibodies and you haven't found one that's working for you, maybe keep trying it a little bit longer. All right. All right. Well, thank you so much, Dr. Smith, for joining us today. And thank you, everyone who is listening in. I hope we had something for each one of you. Please join us again next week on the weekly videocast and podcast of the National Headache Foundation. Thanks again.